Clinton with the Heart of Medicine, and actually today it is June 1st. It's June 1st. Wow. So, okay, June 1st, about 10 p.m. It's a Sunday, and I'm doing this ABIM Pearls video. This is video number 15, and as you already know by now, this video is for anyone preparing for the internal medicine board exams, or it's also for anyone that wants to learn internal medicine, medical students, residents, etc. Of course, as I prepare for the ABIM certification test, which I will be taking in a couple months when we'll be down in Miami. Well, that's the reason. So let's get to the action. This is a video that it got a little late. It's 10:30 p.m. But we're maintaining the consistency. So let's go to the pearls. And yeah, so this first question, the main pearl with this question is that we have to think about what are the most important things to consider in a patient that has major depression. What is most suggestive of major depression? So all your patients will have different stories. All of them will have different information, signs, symptoms. But you have to think to yourself, does this patient actually have depression, or is this patient maybe just going through a tough medical condition? Because in this case right over here, this patient is going through a lot, going through a tough medical condition, is going through cancer, through chemotherapy and the whole thing. And the main question here is like, what of this is most concerning for depression? And well, I thought that thinking about that was going to be what was the right answer, but I wasn't thinking it clearly because as I usually reason and think in Spanish, when I have to translate things into English, sometimes I get some confusion in those answers. Just thinking about that, that's normal. Like anyone can think about that, and even more if you're having cancer, it's gonna be normal for you to probably think about that. A different thing is thinking about active like dying soon or wanting to die, right? Thinking about suicide, wishing to be dead, that would be concerning. But this wasn't the case. The option here just says thinking about death, which is expected, normal. But the answer here was withdrawal from family. So when you are thinking about depression and you have a complicated medical condition, what you have to focus on are here you have it. Let's see, the non-somatic symptoms of depression, okay? Diagnosis is challenging as somatic symptoms of depression can overlap with physiological effects of cancer itself and its treatment. So you wanted to check the non-somatic symptoms of depression. What do you have to emphasize? You have to emphasize things such as loss of interest and pleasure in activities. You have to think of the feelings of worthlessness, excessive guilt, and suicidal ideation. So the loss of interest in spending time with family and the inability to engage with them in shared interests are the most concerning signs of depression. That was the right answer there. Now we're going on to the next question. Okay, this next question, let's see what's the main pearl here. And let's see. Okay, yeah, this is a patient that has systemic candidemia, or what does this patient have? This patient has a fungal infection, and the cultures, let's see what we have here. Ground glass. Okay. No, they aren't telling you exactly which fungal or systemic fungal disease the patient has. They're just telling you that the patient is on broad spectrum antibiotics with vancomycin and piperacillin tazobactam, but is failing to improve in 3 days of treatment. And the computed tomography is showing you several 1 to 2 centimeter nodular lesions scattered throughout the lung with surrounding ground glass attenuation. So basically, they took cultures and the whole thing, and they're asking you what's the best next step in management. So yes, they're inferring that we're not covering for something. That's the question here. What are we missing? What are we not covering for? So as you can see, I ruled out all the things that were not fungus because I did think that there was a fungal thing going on. I wasn't sure which fungus, and I wasn't also like sure which medication we were going to give for it. So amphotericin B and voriconazole, both of those are for fungi. But what I failed to recognize here was that which fungal infection. So basically, the fungal infection they wanted me to think about was invasive aspergillosis. And if you're thinking about that one, you would give voriconazole. So we're gonna see why it was voriconazole and why it was not amphotericin B. So here, let's see the different types of aspergillus infections are right over here. We will get to this in a second, but some of the main signs for you to think about it being the aspergillus was that the patient, yeah, sometimes the symptoms are usually non-specific and usually mimic bronchopneumonia, fever unresponsive to antibiotics, cough, sputum, dyspnea. That's all the things this patient has. And IPA, or invasive pulmonary aspergillosis, is one of the most common causes of hemoptysis in neutropenic patients. So this patient was definitely neutropenic. They gave us information on his neutrophils. His leukocyte count absolutely was 800. 50% was neutrophils, meaning only 400 neutrophils. That's severe neutropenia. So that's why in the onset of non-response to antibiotics and the CT findings, you would expect a fungal infection. And yes, so the enzyme-linked immunosorbent assay on serum or bronchoalveolar lavage fluid can be used to detect galactomannan antigen present in aspergillus cell walls, especially in hematologic malignancies. Voriconazole has become the gold standard as primary therapy for invasive aspergillosis. Voriconazole was more effective than amphotericin B as initial therapy for IPA, invasive pulmonary aspergillosis, and was associated with significantly improved survival, 71% versus 58% respectively in an RCT. So there you have why it was voriconazole. I was hesitant of actually choosing amphotericin B because it's also known in the past as amphoterrible. It has electrolyte derangement problems. It also hits the kidneys pretty hard, and creatinine was already high. But I was also thinking voriconazole. I wasn't sure about it. Like, I don't recall us giving the voriconazole that often in the hospital, but at the same time, yeah, not necessarily gonna be the like what we do in the hospital isn't necessarily the gold standard, of course. So why wasn't it amphotericin? It was because here we have amphotericin was choice A. It says, well, choice A isn't, yeah, if you have invasive aspergillosis, it's going to be voriconazole. That's about it. So what else do we have here? That's it. Let's go on to the next question. This other question is a patient with prostate cancer that has metastasis to the bone. So the patient has multifocal bone metastasis, is having a pain. So pain is 7 out of 10. And the patient's medications are leuprolide and zoledronic acid. And the question is asking you, what do you do as a next step in the management of the pain? So I wasn't sure what to do about this. I read the options and I read several opiates. So I'm like, there's several opiates here. Probably that's not going to be the answer. So I just thought about the other two options. One was leuprolide discontinuation, and which is an androgen deprivation therapy, of course, which is what you want to do in prostate cancer. You don't want to stimulate the prostate cancer anymore by testosterone. And docetaxel plus prednisone is chemotherapy. But the question is asking you, what will you do about the pain? So the actual answer was oral morphine. And the reason for that was because look at the other options. Methadone is usually never the answer. Methadone has to be given by a specialist. It's not just anyone. It's not usually not a good idea. You can get in trouble giving patients methadone because it's highly, yeah, like erratic. It's very addicting. It's very problematic. So actually, there's a lot of medical professionals which I think methadone probably shouldn't even be an option out there. So this should only be with a very good pain specialist. So that's probably not going to be an answer on mostly any question of what's the best pain medication to give. Then you have fentanyl patch. Fentanyl patch is long-acting opiate, but what they wanted to tell you here is that the onset of long-acting opiates will not be like right away, and you want to treat this patient's pain sort of right away. So you want a short-acting opiate. So oral morphine is your answer right here. And of course, you can also add a fentanyl patch. Once you know the dose you need to control the pain with short-acting opiates, then you can probably add the longer acting opiates based on calculating how much was needed with the short course or short acting opiates. So eventually you want to, after a couple of days, after you have controlled the pain with short acting, you then add the long acting and you reduce the short acting and hopefully rely more on the long acting. But you always have to have available the short acting. So it does not mean that patients with the that already have been transitioned to long acting opiates will only need that, because sometimes for breakthrough pain, that's when you will need the short acting opiates, and all these patients should have it available, right? PRN only if strictly necessary. Also, remember that opiates are not the answer choice for pain in any patient. Like it's in strict subpopulations. When you are not able to do the trick with NSAIDs, with the multimodal therapy, NSAIDs, acetaminophen, etc., then you have to resort to opiates. And cancer-related pain is one of those indications where an opiate makes sense. So this patient, of course, was a good candidate. That's the reason why oral morphine. And basically, let's see. What else can we add to this? This is a nice little table. So cancer pain management. If the chronic cancer-related pain is mild, only 1 to 3 out of 10, you try multimodal non-opioid therapy. If that works, that's perfect, right? If that does not work, then you have to think about the opiates. Or if your cancer pain is moderate to severe, meaning 4 or more out of 10, then you will do the short-acting opiate. Here you have some options: oxycodone, morphine, plus minus of course, the non-opioid medications. And here you have multiple daily doses or sleep interruption. That would mean that you will have to go to long-acting opioid. So if the short-acting, you just need one here, one there, you probably don't need the long-acting option, right? But if you have, as you saw here, you rely on many doses of the short-acting, or you have problems with sleep interruption due to pain, you probably have to do the longer-acting version on top of that, okay? And that's it. Now we're going to the next question over here. So this next question over here basically is telling us about a 48-year-old female that has rheumatoid arthritis. It is rheumatoid negative, so rheumatoid factor negative or seronegative rheumatoid arthritis. And the question is, how do we treat this? So, well, the patient was started on naproxen and all NSAIDs, and the symptoms improved, but she has rheumatoid arthritis. What do you want to do? Well, you don't just leave her there. You already have erosive findings. You can see X-rays here showing mild erosions of the proximal interphalangeal and metacarpophalangeal joints. So you want to use a DMARD, which is disease-modified anti-rheumatic drug something. So the first line is always methotrexate, unless you have a contraindication. So that's the right answer. You do methotrexate, and if you're good on methotrexate, that's gonna be it. Sometimes you need more things, but you will start with methotrexate because this will reduce your relapses. It will reduce, it's gonna be a chronic medication that will definitely help. So let's see what we're missing here. Well, here we have the different DMARDs. Of course, first line will be methotrexate because that's the gold standard one, first line one for rheumatoid arthritis. And here you have some of its side effects. Another one is leflunomide, which is a pyrimidine synthesis inhibitor. You also have hydroxychloroquine there, sulfasalazine, TNF inhibitors. Okay, the whole thing. So let's see what else we have. That's about it for this one. And let's go on to the next question. This next question is telling you about psychological or psychiatry, right? This is psychiatry. So this is a 24-year-old female. She dropped out of college 3 years ago, has been unemployed and living at home. I'll read some things here so we can get to the answer a little better. Over the past year, she has become increasingly isolated from her friends, spends most of the day alone in her room on the computer, and has no motivation to look for work. The patient won't go outside because she is convinced that people on the street are talking about her. She eats only food that she has prepared herself because she fears someone may be trying to poison her. Patient has no medical conditions or no medications and smokes marijuana twice a month, no alcohol. And you see that she's thin, disheveled, and is avoiding examination. It makes poor eye contact, gives very brief responses, etc. So, which of the following is the most likely diagnosis? So you can see that I got this one incorrect. I chose schizotypal personality disorder because I thought to myself, I'm not seeing any hallucinations here. And somehow I was just expecting the question to have a hallucination there for me to say, oh yeah, this is schizophrenia, right? But since I didn't see a hallucination, I thought to myself, maybe this is her personality, and maybe these are her weird thinking patterns. And no, that's not it. Remember that yes, schizotypal personality disorder is the one that is called magical thinking. So yes, these people can seem sometimes as if looking like this patient, but look, this is affecting this patient in many different spheres. Remember that schizophrenia has the negative symptoms, and those negative symptoms or findings are not only the hallucination. So it can also be the withdrawal, right? So here you see clinical features of schizophrenia: negative symptoms, flat affect, poverty of speech, lack of motivation, social withdrawal, and hedonia. So this patient definitely has several negative symptoms. And yeah, the lack of positive symptoms does not mean this patient did not have schizophrenia. Well, at least the lack of hallucinations, because there's other positive symptoms, such as the delusions. So yes, that delusion of people talking about her, that's a positive symptom. Okay, and let's see what else we have. Of course, these managing these patients is extremely complicated because they first have to sort of believe you and understand that they are in the wrong, and they have been having this mental framework for sometimes months, years. So yeah, they need psychiatry consultation, antipsychotics, psychosocial interventions, the whole 9 yards. And let's see why it wasn't schizotypal personality. So schizotypal personality is characterized by a long-standing pattern of odd, magical thinking and eccentric behavior, but it does not explain this patient's persistent, well-formed delusions and recent decline in functioning. Okay, so that's another point. Schizotypal personality is going to be this person, a person that has been that way ever since people remember her, right? Because it's personality, and you're born with your personality, and that's just the way you are. It's not something that will change within the past couple of years. So yeah, that's it for this question. Let's go on to the next one. This next question is important because it is about pregnancy. So the main thing here is, in a patient that is pregnant, which are the recommended vaccinations? So this patient is healthy in general and is 29 weeks pregnant. And which of the following vaccines is recommended during pregnancy? So remember that you don't want to give live attenuated or any live vaccines during pregnancy. So a mnemonic I had in the past was Mr. B JAPS. I'm not sure if I made this mnemonic up or it was already something that was out there, but it's a good mnemonic. I always remember it. And Mr. B, Mr. was like MMR, so that's why. Well, I didn't rule it out here, but it's a live one. You don't want to give that. So that's Mr. V is varicella, so you don't want to give varicella zoster vaccine. That's Mr. B. Jap. Y I think is yellow fever. A is what can A be? I'm missing one there, and it ends in ps. Yes, Japs. Oh, HPV is another one. And I'm missing one there, but we will see it in a moment. So those you want to avoid, of course. And now the question is, of the other ones which you could potentially give, which one will you recommend? So pneumococcal vaccine, you know that you only recommend this one for patients that are at risk. So if you tell me, yeah, during pregnancy, unless you tell me the patient is asplenic or the patient has several risk factors that would benefit from the pneumococcal vaccine, then yes. But this patient doesn't have any risk factors, so that's not the answer. Intranasal influenza, no, influenza is also a live attenuated one. Correct. The intranasal one, live attenuated, you don't want to give that. The other one, if it's right here on the arm, intramuscular, that's not live, so you could potentially give that one. And let's see. So the answer is tetanus, diphtheria, and pertussis vaccine. That's basically the answer. And let's see why. So it says here, well, we have this nice little table here, vaccines during pregnancy. You have the recommended ones, which are TDAP, inactivated influenza, and the RHO immunoglobulin. Which ones are indicated for high-risk patients? It would be hepatitis B, hepatitis A, pneumococcus, Haemophilus influenza, meningococcus, and varicella zoster. Immunoglobulin, that would be the immunoglobulin, right? It would not be, let's see, give me 1 second. Let's just change this music right here. Sorry about that. Let's go back to the action now. That's a good song we're listening to in the background. So some medications that are vaccinations contraindicated because they are live attenuated are these. So my mnemonic, Mr. B, JAPS. I don't have the yellow fever. I don't have the, what's the A? Would be maybe attenuated influenza. And the P would be maybe HPV, I guess. Those you want to avoid. Why would you want to give the Tdap to a pregnant female? The reason is Tdap vaccination is recommended for women during each pregnancy, regardless of previous vaccination history. The Tdap vaccine is safe during every trimester. However, vaccination during the third trimester is preferred as it both facilitates the maternal antibody response and provides passive immunity to the neonate. It is also recommended for family members who have not been recently vaccinated and will be in close contact with the newborn. So that would be the answer with that. Okay, let's go on to the next question. This next question, I got it incorrect. This is a question that people that we are usually consulted in cardiology for, and this is nice to know. It is refreshing to learn that candidemia. So you have a patient with candidemia. You know that nowadays, almost always, oh, candidemia. Yeah, it's the same. People, you'll hear people saying it's the same thing as Staphylococcus aureus bacteremia, and the patient needs a transthoracic echo to rule out any vegetation. Well, wait a second. There's a caveat to that, and that's why I got the question incorrect. So I did, as you can see, I ruled out all the other options, and I'm like, I think these two make sense. If you have a patient with candidemia, you always screen for a dilated ophthalmoscopy examination. Why? Because you want to make sure that there's no problem there, because if there's a problem in the eye, you're risking the patient going blind. It's not that frequent, but it can happen. But echocardiography is not always necessary, because only if you have more criteria to suspect endocarditis, you would do an echo. So if you tell me that, oh, the patient has candidemia and a new murmur, okay, do the echo. But just the candidemia is not a criteria for you to order a echo. So let's just read through whatever we were missing. Why do you want to do the dilated ophthalmologic examination? Because you want to evaluate for endophthalmitis. Endophthalmitis. Yeah, in patients with candidemia. And it says that, let's see, with the American Academy of Ophthalmology recommended examination in patients who have ocular symptoms or are unable to report symptoms to avoid overdiagnosis. Although endophthalmitis occurs in a small minority of patients with candidemia, its early identification may reduce the risk of vision loss, and its incidence may be increased due to increased use of echinocandins, which do not achieve high intraocular concentrations. And the transthoracic echo, we already said, we talked about when to order it, and it would be only in persistent positive blood cultures or other criteria for endocarditis. Okay, let's go on to the next question now. Let's see if this, before we do that, let's see if this patient had any eye symptoms, visual symptoms. Receiving this over the. No, there's no visual symptoms. You can see here there's no visual symptoms. So yeah, that's the right answer. And here you could go through it if you wish to review. Okay, let's go on to the next question. This next question, clinical pearl, is important because it talks to you about how to manage post-obstructive diuresis. So when you have a patient that has a post-renal acute kidney injury due to post-renal obstruction, basically, it can be both of the ureters that are obstructive due to stones, or it could be a prostatic hyperplasia, whatever the reason is. Once you relieve the obstruction, once you put in a Foley catheter, what are you expected to find? Well, the more time this patient was having this obstruction, the more probably volume this patient will have to pee out. So this patient will pee a lot. That's what you're expecting, a lot of pee, because they had a lot of volume in their system that they have to now take out. And I wasn't exactly certain what to answer in this question. I got the question correct, but I didn't think that much about the reasoning, because some of the options say that you would check the diuresis and that you would replace, as you can see here, match urine output. So they're telling us that this patient was urinating 600 cc per hour after they put in a Foley catheter. So you might want to do a replacement of 600 cc or even more, right? Well, that's incorrect, because the right answer is that when you replace exact one-to-one fashion, it's more problematic, because you can actually induce a polyuria or over-diuresis for many hours, and you can end up actually generating a vicious cycle where this patient could be even peeing 10 liters per day. So what you want to do is, in general, replace about half of what this patient is urinating and go from there. So if you replace half these 600 cc, like in this case, you're given 200 cc, 200 to 300 cc, then you will reassess in an hour and you'll go from there, and that's going to be better, because you might not induce this vicious cycle where you think, oh, we have to replace everything this person is urinating. That's not the answer, because this person had a whole lot of more volume in their system, and they have to take it out, and you don't have to replace all that. So that's basically the reasoning through that. And only wanted to add a caveat there. There's sometimes partial bilateral urinary obstruction, and it can also result, so not complete obstruction, generating anuria. There can be partial urinary obstruction, and it can result in normal to slightly increased urinary volume, possibly due to renal tubular damage and secondary concentrated defect. As a result, patients with renal failure and urine output more than 1 liter per day may still have significant obstructive uropathy. So that's also to consider. So you can have a patient that is doing horribly, with their kidneys are doing horribly, and just because the patient is peeing is not a good sign. Maybe this patient is peeing, but this patient is having a very bad partial bilateral urinary obstruction. So if you are concerned this might be happening, of course you have to do imaging to rule it out. And that's the main thing here. Now let's go on to the next question. This next question is a pregnant female, 18 weeks gestation. She was found to have a DVT. So what's the treatment, basically? So there's different options. In summary, the best treatment for, the best anticoagulant in pregnancy is going to be low molecular weight heparin, okay? And what do you have to do? You just have to give low molecular weight heparin for most conditions in pregnancy. If you have a mechanical valve, that will change a little bit, right? But you will ultimately give low molecular weight at some point in time, but we won't get into that. For most thromboembolic things in pregnancy, the answer is going to be low molecular weight heparin. And when you are about, when the female is about to give birth, then you do a change. Then you hold the low molecular weight heparin 24 hours before giving birth. You transition to unfractioned heparin infusion, and you stop it 4 to 6 hours before the actual birthing. Why is this? Because remember that low molecular weight heparin has a half life that is way more prolonged than unfractioned heparin. So that's why you don't want to give low molecular weight heparin like right before birth, because you're risking an unnecessary hemorrhage and complications. So that's basically the main thing to learn from here. Let's see. What else do we have here? So we already talked about low molecular weight and unfractioned. And let's talk about warfarin. So warfarin, of course, is oral. Maternal considerations. It says most effective, best compliance due to route. Benefits outweigh risks during second and third trimesters for high-risk patients. Okay. Yeah, if you have a patient that really needs it, you can potentially give it second and third trimester. Never give it first trimester because it is teratogenic to bone and cartilage and can can generate fetal bleeding. This paragraph right here explains the procoagulant effects of pregnancy, which are associated with a decreased protein, the natural anticoagulant factors, protein S and protein C, and there's more venous stasis, and all those things generate risk for venous thromboembolism. And we already talked about the rest of this. In a patient with DVT, anticoagulation, of course, after they give birth, anticoagulation is restarted 6 to 12 hours after that and continued until a little bit over 6 weeks postpartum. So that's interesting because that's going to be only 6 weeks, 40 something days. It's not going to be months, right? So usually when you have DVT in general, you're going to treat for 6 to 8 months. But in pregnancy, it seems since it's going to be sort of provoked by the pregnancy, you might not have to prolong it so much. So it says here 6 weeks postpartum. Okay. And factor 10 inhibitors, no, currently not enough information to risk it during pregnancy. Next question is a patient with a prolactinoma. So the main clinical pearl here is that when your prolactin is elevated, it depends how high it is for you to think what's going on. So yes, if you have high prolactin, it can be due to medication. So if you have dopamine antagonists, that can generate a rise in prolactin. But you can also have prolactinoma. So how can you differentiate them? Well, initially with the lab, you just have to look at the numbers. Prolactinomas will usually be numbers above 200. So whenever you have a prolactin level above 200, such as this patient, don't think this is caused by medication. Don't think this is caused by basically anything else than a prolactinoma. So above 200, think prolactinoma. So if you think prolactinoma, your next step in management is actually an MRI of the head. So in this case, what did I do? I didn't remember that didn't think about this cutoff. So I saw that the PSH was a little bit high. And you know that if you have hypothyroidism, what happened is that if you have, hypothyroidism, it's because your gland is not working. Would that be primary or secondary? Let me remember this. Primary hypothyroidism, right? Let's see. Occurs when the thyroid gland itself. Okay, so when you have primary hypothyroidism, meaning that the gland is not responding, what will happen? You will have a feedback mechanism. The feedback loop will make your not the hypothalamus. Yeah, the hypothalamus generate more TRH, which is thyrotropin releasing hormone. And the TRH will try to stimulate the pituitary to generate more TSH, or release more TSH. And the TSH will try to stimulate the thyroid. So it is known that hypothyroidism, primary hypothyroidism, leads to elevated TRH. And elevated TRH can also lead to elevated prolactin. But I marked that question incorrectly because I didn't recall that once the prolactin is very high, above 200, this is not hypothyroidism. This is prolactinoma. And the other thing I didn't probably get was that if you actually have hypothyroidism, you can base yourself probably off the TSH level and start treatment off from that. So probably getting all these different labs, total T4, free T4, and free T3 levels wasn't going to be the answer. So let's see what we're missing here. Of course, the symptoms and signs of prolactinoma are going to be the secondary amenorrhea, bilateral galactorrhea, and hypogonadism. And we already talked about the elevated levels and how to scan for that. The other things we can talk about is that prolactinomas that cause hypogonadism or neurological symptoms secondary to Mass Effect are treated first line with dopamine agonists such as cabergoline and bromocriptine and followed with serial MRIs. Surgery, for example, transsphenoidal resection, is reserved for patients who fail medical therapy, which makes complete sense. You don't want to be invasive unless strictly necessary. And now we're going on. Well, let's talk about the hypothyroidism. I already mentioned that, but this is going to be better explained. Serum TSH is the most sensitive test to diagnose hypothyroidism and monitor response to levothyroxine therapy, and therefore can be used alone to adjust dosage without checking total T4, free T4, and free T3. Okay. Next question is interesting because this question is telling you there's in summary bacteremia due to Clostridium septicum. Which of the following additional studies would be indicated in this patient? So this is just something you have to memorize, but I think there is understanding in here because if you have Clostridium septicum, just think about it, right? Clostridium septicum. What organ do you think Clostridium usually septicum will be in? So Clostridium is, yeah, usually associated with Clostridium difficile, which is associated with the pseudomembranous colitis. Okay, but this is not Clostridium difficile, it's Clostridium septicum. What does septicum like actually mean? In Latin, it's just pure crap, it's trash. And where do you find the crap? You find it in the colon, right? So whenever you have bacteremia due to Clostridium septicum, you are always obligated to do a colonoscopy because it's often telling you, hey, there's something going on in the colon. It's either horrible IBD, inflammatory bowel disease, or it's colon cancer. So that's what they wanted you to do, a colonoscopy. So there's other bacteremias that you should also think about screening. So when you have Streptococcus bovis or group B strep, you do a colonoscopy because it's similar to what you find with Clostridium septicum. When you have non-typhoidal salmonella, you check an HIV test. When you have candidemia, we already talked about it some questions ago. It would be an ophthalmologic examination. And that's it for this one. Let's go on to the next one. So this other question right over here, this is an interesting question because this shows that we don't always practice medicine the same way we read the medicine. Sometimes defensive medicine is, yeah, it's usually more defensive than the guidelines. Because in this patient, a 54-year-old male comes into the hospital, was playing soccer, and was found to have a deep vein thrombosis, had a fracture, I think. What happened? Injured his leg 2 days ago playing soccer, had some swelling the next day. Okay, didn't have a fracture, but was found to have deep vein thrombosis. When he came into the hospital, his platelet count was 210,000 and was started on, of course, warfarin, heparin and warfarin. And his platelet count went down from 210,000 to 130,000. And his INR is basically not changed yet. And the question is, which of the following is the best next step in management of this patient? So whenever you read this, you probably think, oh, can this patient be having HIT syndrome, heparin-induced thrombocytopenia? So the answer is maybe. Remember that there's a HIT score. Whenever you think a patient might have HIT, you always have to do the HIT or 4T score. I think it's called 4T score. Yeah, one is time, one is total platelet reduction. You take into account also the clinical context, the whole thing. So what I remembered from this score, it was timing. Oh, this happened pretty quick, like in 24 hours. I also remembered that platelets went down from 210,000, but to 130,000. So it wasn't that much. It went down to, yeah, not 50%. It was less than 50%. And what else? The dog is thinking, we just heard something hit pretty hard somewhere here. So I think I'm going to pause the video here. We're going to go check what happened. You're going to hear the dog bark. I'm going to make a sound so easy. So yeah, the dog is ready to go out and check what's up. Let's just finish this question here and we'll see what's up. But you have, why was the answer just continue heparin infusion and observe? Because type 1 heparin-induced thrombocytopenia is a non-immune mediated thrombocytopenia due to an immediate reaction to heparin therapy. Platelet counts rarely drop below 100,000 and usually recover spontaneously regardless of heparin continuation or discontinuation. So only thing that had to be done was wait a little bit more. If the platelets dropped more than 50% or more than 100,000, then you probably would have had to discontinue the heparin, do argatroban, and probably check the platelet factor for antibodies. And 1 second. See you later.